6-year-old female with vomiting and abdominal pain. This is CT scan of the abdomen and the pelvis. Okay. So as you can see here, there's distended stomach and can you see the duodenum here? So distended stomach and proximal small bowel. So let's see the distended proximal small bowel. So here this is the distended stomach and the proximal small bowel. Okay. This is the jejunal loops. Okay. And here the ileal loops with the distal small bowel and colon completely collapsed. So if you go down, you can't see any distended colon or distal small bowel loops. Can you see these collapsed loops? Yeah. So the distal bowel loops and colon are collapsed, are completely collapsed. Completely collapsed. Okay. There's a transient point in the mid small bowel in the lower abdomen. I will show you this transient point. Okay. So focus here. Okay. Can you see this? Can you see this ileal loop? Okay. This ileal loop will turn into a collapsed loop here. So the distended ileal loop here will be collapsed on the next cut. Can you see this? Yeah. Here. So this is a transient. There is a transient point at the mid bowel loops, okay, in the lower abdomen, at the mid small bowel, in the mid small bowel, in the lower abdomen. Also, there is evidence of previous hysterectomy, and I will call it a previous subtotal hysterectomy. Why? Okay, I will show you the signs of the previous hysterectomy. The first sign is the lower midline anterior abdominal wall scar. Can you see this? Okay, so here, this is the lower midline anterior abdominal wall scar. This is the scar, okay? This means that this patient has had or had a previous abdominal surgery, okay? Okay. Next sign of a previous subtotal hysterectomy is here. Can you see the surgical clips here around the cervix? Surgical clips. Yes. Here. These are the surgical clips, okay? And this is the colon. Sorry, this is the rectum, okay? And here should be the area of the uterus, okay? There is no uterus here, and instead this is the urinary bladder, okay? And you will see the cervix in the lower cuts. Yeah, this is the cervix, okay? and the surgical clips around the cervix. All of these, along with the midline lower abdominal wall scar, all of these are signs of, the scar, all of these are signs of previous subtotal hysterectomy. Subtotal hysterectomy means that only the body of the uterus is removed, however, the cervix is still seen as in this patient, okay? Also in this patient, as you can see here, there are multiple gallbladder stones, okay? So look here, this is the gallbladder. These are, can you see the multiple gallbladder stones? Okay. This is the right kidney. This is the left kidney, okay? Can you see this? Left renal calculus, okay? But there is no sign of obstruction or back pressure changes, so this is non-obstructing left renal calculus, okay? Non-obstructing left renal calculus, okay? So in this case, in addition to the proximal small bowel dilatation and the distal bowel collapse, as you can see here, there is minor stranding of the mesentery. So minor stranding of the mesentery, but no free air, no free intraperitoneal air, okay? Can you see the minor stranding? There's also extensive vascular calcification with advanced atheroma. Can you see the advanced atheroma here? Okay, this is the first branch of the abdominal aorta. Okay, okay, this is the celiac trunk, and the celiac trunk has given the splenic artery. Can you see the extensive vascular calcification and the atheroma formation within the splenic artery? Look. Okay. Then the abdominal aorta gives the superior mesenteric artery. Can you see the atheroma formation at the origin of the superior mesenteric artery? Okay, and if you go down, this is the superior mesenteric artery. Can you see the calcified plaques and narrowing? Calcified plaque and narrowing of the superior mesenteric artery. Okay. Also, there is osteopenia with multiple compression fracture, maybe due to osteoporosis. So, can you see here, the cortex is not continuous here. This means that there is compression fracture here. Okay, can you see the compression fracture? Okay. Uh, this is a normal vertebrae, okay? No fractures here. So the compression fracture is seen in the lower thoracic and in the lower thoracic vertebrae, maybe due to osteoporosis. There is also cardiomegaly. Okay, so yeah, as you can see here, there's cardiomegaly. Ground glass changes in the right middle lobe. So as you can see here, this is the right this is the right middle lobe, and here this is the ground glass opacification in the right middle lobe. All of these ground glass opacification in the right middle lobe. Answer interpretation here. I have mid-small bowel obstruction. Mid-small bowel obstruction. Okay. Given the past history of abdominal surgery, this is most likely to be secondary to adhesions. So whenever you see small bowel obstruction in a case with a history of abdominal surgery, think of adhesions as the cause of the small bowel obstruction. Also, the changes in the right middle lobe, the ground glass changes in the right middle lobe may be related to the post-surgery state. Okay, so this is most likely to be inflammatory changes in the right middle lobe. Okay, inflammatory changes in the right middle lobe and small bowel obstruction, mostly due to adhesion. But there is no evidence of perforation. Okay, so whenever you see small bowel obstruction, okay, try to look for any evidence of perforation. Okay, there is no evidence of perforation, no free intra-abdominal air, no free fluid in the abdomen, in the peritoneum. Okay, no intraperitoneal free fluid or free air. The management here, there is no need for more radiological investigation. Okay, so this patient needs to be referred to surgery. Okay, so urgent surgical referral is recommended here, along with urgent nasogastric tube placement, okay, to relieve the obstruction here. The small bowel obstruction needs to be relieved by placement of nasogastric tube, which is better to be advanced into the jejunal lobes, okay, to decompress these distended and fluid-filled small bowel lobes. So I think this is the management.